Okay, welcome back to the second session of this British Heart Valve Society AGM. There are perhaps two things that exercise us a lot in the valve community. One is how, when, where, or if to apply the NICE guidance on endocarditis prophylaxis, and the second is how not to get sued. So we've made joint endeavour here, and are hopefully going to explore these issues in a slightly different session, which focuses both on endocarditis prophylaxis and the medico-legal aspects thereof. And we're going to start with a brief introduction. So I must introduce you to the team. So we have Dr. Chris Primus here, works here at Barts and is the linchpin of our endocarditis MDT process, so knows all the endocarditis cases in this area. We have Bernard Prendergast, probably one of the country's leading authorities on endocarditis, author of the very influential recent Lancet paper on the effect of the introduction of the guidance, and Mark Trafford QC, who's hot-footed up from Southwark Crown Court to put us through our paces, only to hot-foot back again, I think, in a hurry on the bike. So welcome to the panel. Thank you very much. And we're going to start with a short session on Mark, just explaining some of the background to medico-legal that perhaps we don't understand maybe as well as we ought to. So Mark, thank you very much.
Guy, thank you very much. I'm not sure how I can hot foot on a bike, but I will do my best. Ladies and gentlemen, it's a real honour to have been invited to speak to you today, in particular because I have known your convener, Dr. Lloyd, now for, I think, and he wouldn't mind me saying this, 30 years. We were at school together, so I watched him come along very well. He was going, in fact, to be an actor. No one seems surprised by that when I say that, Guy, but to everyone's benefit, he no longer is, although he may still aspire to be so. We also have the great advantage that Guy, in fact, at one stage, quite by accident, became my treating physician. So we have a particularly close relationship. Ladies and gentlemen, my job today is to literally skirt through some, in very, very short form, the issues that affect medical legal work, the landscape in which you have to operate. I hope I'm going to deal with it within about 10 minutes, in fact. What I propose doing, and I've told Guy I'll do this, is at some stage in the next week, I will put onto your website, I assume you do have a website, a short paper setting out in some detail, I hope, with some copies of authorities, the background to how you should operate in relation to NICE guidelines and everything else. The real change since I started practice, and I think since Guy started practice over the last 25 years or so, is the nature of the change in the relationship between doctors and patients. I overlook in my house a valley the top of which is Sir Russell Wilbrock of Wimbledon's old house. One of the most famous, I think, cardiothoracic surgeons since the Second World War. In those days, decisions were made, and only made, by doctors. The idea of patient consent would have been, to him, fairly ridiculous. I know that because my mother was a nurse at Guy's when he was the professor of surgery there, and she has described what he's like. Since about, I suppose, the middle of the 80s, the prepositions have changed. Decisions have gone from being made by doctors to being made with patients. And from that flows a discussion which I know is going to take place later in the course of this session about consenting patients in relation to guidelines, whether NICE guidelines, European guidelines, American guidelines, or any of the literature going on at the time decisions are made. The real mainstay of medical legal work, is, I'm sure you've all heard at various talks you've no doubt had over the years, is a case called Bolam. Bolam took place in 1957, and it was a case where a patient attended the mental hospital at the time to have electroconvulsive therapy. In those days, I should add, medical cases were in fact decided not by courts on their own, but by juries. And so the juries had to consider, as they do in criminal cases at the moment, the facts that lie behind what took place in the hospital. And what took place in Bolam was the person concerned, attended to have electroconvulsive therapy, was not given or advised about muscle relaxant, and was not told about the benefits or otherwise of being strapped down. As a result, and not surprisingly, he went into significant convulsion and caused significant injury. I see you shaking your head there, hearing about this. Before I get to the legal test that took place, I ought to point out that in fact the hospital were found not to be negligent. So one must be careful in using the norms of today to judge yesterday. The reason is this: the test that emerged from Bolam was one where a doctor was not negligent if he or she acted in accordance with a practice accepted as proper by a responsible body of medical opinion. Now, of course, the test that arises from Bolam does abrogate the standard applied by the courts to your own profession. It sort of empowers doctors more than any other area of negligence. It is, if you like, a doctor's knows best approach. It's rather paternalistic, as I'm sure you understand, and you're shaking your head rather indicates. But in fact, at the time this took place, there was some controversy over the use of relaxants in electroconvulsive therapy. And there was also, amazingly it may seem now, some controversy about whether one uses restraining methods when one was giving ECT. The fact that there was a responsible body of opinion that took the view that the decision taken by the hospital management board at the time, the legal entity, if you like, on behalf of the doctor, there was that responsible body of opinion. They found that the hospital was not negligent. And that remains the test even now, 50 years later. So the test is, in terms of medical negligence, is there a responsible body of opinion that would take the same view that was taken at the time the decision was made? There has been slight changes in terms of the nuance of that particular test when it comes to diagnosis and general treatment. It's completely changed in relation to consent. I'll come to that in a moment. As you would expect, I'm sure, there are often conflicting bodies of medical opinion. And whilst Bolam made the perfect test for about 30 years, in the mid-80s, in about 1985, again arising from a mental hospital case, in this case a case called Sidway, against the Board of Governors of Bethlehem Hospital, the issue slightly changed. In that case, Sidway was a case where a young lady went in to receive treatment in relation to back and shoulder injury. As a result of which, the surgeon decided to undertake a compression operation. I'm not a particular expert on neurosurgery, but relieving pressure in the cervical spine. There's a 1% chance, or there was at the time, a 1% chance of paraplegia that arises when one undertakes that particular type of surgery. Some of you may recall from your medical school days. She wasn't told about that. Now, at the time, the view was she didn't need to be told about that. So the majority opinion in the House of Lords, because in case they went to the House of Lords, the majority opinion was that she didn't need to be told about a 1% chance of it because, of course, she would have gone ahead and doctors know best, and that was the operation that should have taken place. In that particular case, a well-known judge, you may have heard of him for other reasons, a chap called Lord Scarman, said this is utterly ridiculous. The world has changed. Sir Lancelot Spratt is now dead and buried. The idea that doctors cannot involve patients in these sorts of decisions and they don't understand the nature of risk should be confined to the dustbin. I emphasise that Scarman was in the minority in that particular case, and the majority stuck to the old Bolam test. However, the door then opened, because what Scarman said is we should now have a much more patient rights-based approach, and doctors must work much more with patients. He took the view and gave lectures about it later that the standard of education throughout the country was much higher, and people could well understand the notion of a 1 in 100 risk, and they therefore could make a perfectly sensible decision on it. So the test for negligence then, or now in fact is, outside of consent, it is whether the doctor acted in accordance with the practice accepted as proper for an ordinarily competent medical practitioner by a responsible body of medical opinion. So the first standard Bolam test. Slight difference now is if yes, is there any logical reason why that responsible medical opinion may be wrong. So one or two cases have gone and allowed the judges, the judiciary now, to actually weigh up competing medical opinion. Now, you may have your own views about that, I'm sure, as doctors, whether one should be able to do that. But in certain circumstances, judges now can weigh up certain types of opinion. So, for example, one is often faced with a situation, or was faced with a situation back in the 90s and early 2000s, when there is a perfectly responsible medical opinion that was slightly stuck in the past. And I think one of the obvious examples was, for example, if you remember Helicobacter pylori, before somewhere around 1985, I think, no one realised that gastric ulcers, in 80% of cases, would be caused by a bug. And very slowly that became the standard understanding of that sort of treatment. But for a long time, there was what is regarded as a responsible body medical opinion that said, no, this is complete nonsense, this is new science, we don't accept this. And so the judiciary was asked to weigh up competing medical opinion and decide which was the better form medical opinion. So there's that particular, if you like, caveat to the Bolam test now, which is the judiciary can take a much more active role in determining the science which is in front of them. Which leads us to the more important part of today, which is about consent. Now, I know the MDU and the NPS have put up various leaflets about a case called Montgomery against South Lanarkshire. This is now the principal authority governing how doctors should deal with patients before any form of surgery takes place. It arises from a young lady called Nadine Montgomery who gave birth to a son called Sam in October 1999. As a result of an occlusion of the umbilical cord, there was dystocia and Sam was hypoxic for about 12 minutes and thereby suffered cerebral palsy. Mrs. Montgomery had in fact been diabetic and she was a high-risk pregnancy with a 10% chance of shoulder dystocia during vaginal delivery. Although the risk to the baby was very low, it is in fact, as I'm sure you all know, a major obstetric emergency requiring intervention and risk to the mother's health. Most women in this situation do opt, if they are fully consented, for caesarean section. However, Mrs. Montgomery was not advised at her 36-week appointment of the risks, and she proceeded to vaginal delivery. The main reasoning in the Supreme Court, and it was such an important case that they shipped in 7 Supreme Court judges, which happens once, maybe twice every couple of years, was this. The doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatment. The test of materiality is whether, in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk. Or the doctor is, or should reasonably be aware, that the particular patient would be likely to attach significance to it. That is a relatively big shift towards the role of the patient and away from the doctor. In fact, it was rather counterintuitive, but in fact, on the fact of Montgomery, vaginal delivery would have been recommended at the time. You're facing this problem, however. The Supreme Court refused, despite being asked to do so, to reduce the materiality of risk to any percentages. Whilst the 10% risk in the particular case was very clear, it provided no further guidance at all in relation to how to evaluate risk. Since then, and that's Montgomery only was decided in the middle of last year, since then in a couple of cases following on from Montgomery, where it has been said in terms of risk that 1 in 1,000 is the sort of risk you don't need to run past a patient. But the query must be, and I'm sure it's something that will trouble you and will trouble the courts for some time to come, in the light of any guidance as to what sort of percentage you do deal with, I suspect this will come back to court time and time again. For whilst it empowers patients in terms of their subjective interest in what risk might be, it doesn't assist, in my view anyway, doctors in how to explain that. I was discussing this with Bernard earlier today upstairs where you just had coffee. And of course, there are many cases in this type of surgery which he deals with where there are a collection of small risks. There are a number of areas of the surgery that have a 1 in 1,000 chance of this, a 1 in 500 chance of this, a 1 in 1,000 chance of this. And of course, you'll want to know and it'll be too late by the time the Supreme Court hear any case that you may be involved in, you'll want to know what it is you're supposed to take the patient. And one of the problems, of course, I see it like this, it's like being in a mobile phone shop. There's too much choice now, there's too much information. And so if the patient is properly consented before surgery now, they're going to be presented with a mass of information. Now, whilst, of course, and the courts have recognised this, there's access to the internet, everyone goes on WebMed now and all those sorts of things when they've got a cough or a cold. If Bernard was to come along and consent before surgery, some people would say that he has to go through each and every one of the risks that he regards as significant, even if it's 1 in 1,000. And of course, that can panic the patient in making a decision. Doctors are well trained in making decisions on the basis of that risk, and they're educated to a very high standard. But if one's 1 in 500, one's 1 in 1,000, one's 1 in, 200 or so, where is the line going to be drawn? Well, that's impossible now to know. So the Supreme Court, one of the clerks of the Supreme Court, have listed out what they now call the 10 commandments, and I'll put this up on the website at some stage next week. They're fairly self-explanatory and fairly obvious, but in terms of consent, they expect to see full notes, they expect to see a discussion of any alternatives. They expect to see that an adequate time has been set aside in order to discuss the position, as well as for the patient to make adequate assessment of what they hear. There needs to be focused on the individual patient and the individual case, as opposed to sort of systemic and generic risks. The dialogue must be seen to be and recorded to be 2 ways. There should be no focus on, despite what I've just said, there should be no focus on percentages. There must be very, very careful assessment as to whether or not you rely upon the therapeutic assessment. In other words, whether there are certain positions you simply shouldn't tell the patient, going back to the old Hippocratic Oath. You should consider the risks of intervening events, not just the catastrophic outcomes. You should ensure, although how you do this I still don't know, that the patient has full understanding of all the matters that I've just set out, the previous 8 points. And they're made clear that leafleting is not enough. So whilst there has been a shift towards the patient, as in many ways, and there should have been, it's still far too early to see whether this new landscape will in fact make it more difficult for patients with their, if you like, their enhanced autonomy. Will patients now be deluged by sort of lawyer-averse rhetoric from the doctor, who is concerned that if he doesn't go through one of those 10 commandments, that he'll receive a writ he or she will receive a writ later on? My view is the plethora of information can be too much. And I'd say I'm fairly rare in that view. Most of the lawyers will say the more information, the better. I'm not still entirely convinced by that, simply because risk analysis is so difficult. I am perhaps slightly old-fashioned and go for the Robert Hutchison's advice, not to put knowledge before wisdom and science before art. Because what needs to be left within this is clinical judgment. The assessment a doctor makes in relation to an individual patient, and his assessment about how much the patient could understand in their circumstances of what's going on. So whilst, of course, I am entirely happy as Queen's Counsel representing sometimes doctors, sometimes health authorities, sometimes others, to have this area of law murky and therefore leading to more cases to decide this, I am concerned in relation to clinicians, the new case on consent, whilst representing the fundamental shift away from doctors towards patients on autonomy, hasn't in fact helped. And I think in this particular case that we're just about to be discussed, and with Bernard's piece in the Lancet and the British Dental Journal on the NICE guidelines and the change in NICE guidelines, that only emphasises the difficulties doctors have in giving this advice to patients. So I'm now going to hand over to Chris, who's going to tell us all about the case.
Good morning, everyone. My name is Chris Primus. I'm one of the registrars here at Barts. I want to take you through a case this morning of an 84-year-old gentleman who went to see his private physician with a 3-week history of a febrile illness, new onset palpitations, night sweats, and a 3-week history of anorexia and weight loss after he'd had a dental extraction. And the history to that was he'd presented to his dentist with a sore tooth. He'd been given a course of antibiotics for wisdom tooth infection, and when that had failed, he'd been brought back to the dentist again and had the tooth extracted. In his background, he'd had a tissue aortic valve replacement at a regional centre, and despite successful surgery at the time, he now had a moderate paraprosthetic leak with normal LV size and systolic function in 2015. And so the consultant cardiologist who was looking at him specifically wrote and told the patient that this constituted a high-risk lesion and that he should have antibiotic prophylaxis before he was to have any invasive dental procedures. Unfortunately, this wasn't done by the dentist despite the antibiotics that were given for the original abscess. On top of that, he also had carcinoma of the prostate and had had prostatectomy and radical radiotherapy in 2005. So in the context of being unwell, the private physician referred him to his local district general hospital, where he was admitted to the acute medical unit. For the first 48 hours, he continued to have high-grade fevers with a moderate increase in his inflammatory markers. He was in rapidly conducted AF, but with a good blood pressure, was given a small amount of bisoprolol, 2.5 milligrams, in order to try and control the rate. He was started on augmentin because there was no clear source of infection, but blood cultures were taken before the antibiotics were given. So within the first 24 hours, they knew that he was growing gram-positive cocci in his blood cultures, and his antibiotics were changed to amoxicillin, and then 24 hours later, gentamicin was added in for synergy. And when the enterococcus finally came back, the decision was made to continue with that antibiotic regime. Unfortunately, in the context of his sepsis being unwell, he developed an acute kidney injury and was changed onto ceftriaxone only. My understanding is that whilst that was bacteriostatic, it wasn't actually going to be bactericidal. And so there was a concern from the microbiologist later on that this may have contributed to what now happens. However, on that antibiotic regime, his fevers settle and he cardioverts to this rhythm. And just in case that doesn't project very well, that's a PR interval of 440 milliseconds. So given that, he remains on the acute medical unit on a monitored bed, but no further action is taken. And unfortunately, 24 hours later, 3 days into his admission, his clinical status deteriorates significantly. He goes into what is described as flash pulmonary edema, but he was probably in pulmonary edema the whole time, has a hypoxic arrest and loses output. He's successfully resuscitated after 20 minutes of chest compressions and appropriate therapy and is transferred to the intensive care unit where he has an echocardiogram. So I think what these images demonstrate is that echo on ITU is not the most straightforward thing in the world. We can see that he now has LV impairment. We can see that there is mitral regurgitation of some degree. And I don't think any of us in these views would be able to be happy with assessing what's going on with the aortic valve replacement itself, although there does appear to be a flash of regurgitation associated in the parasternal long axis view. His apical views are clearer, and we can see that there definitely is significant, when we look at through all of his images, significant mitral regurgitation. But this is the kind of imaging that we're seeing in the 5-chamber view and the 3-chamber view, where you just really can't see what's going on with the aortic valve. There is a discussion when the cardiologists are asked to come and see him about whether, now that we think there probably is endocarditis, whether he would be an adequate or a sensible candidate for surgery. And the feeling was that after a cardiac arrest with new heart failure and confusion when he goes back to the ward and has been extubated, that the risks of operation are too high. But they want to try and work him up because his pre-morbid state was good, and so in the context of enterococcus, the decision is made to undertake a CT PET without cardiac suppression, and we're now 3 weeks or so, or 2 weeks or so into his admission, which showed the low-grade pleural uptake, associated thickening, and the focus of raised uptake within the rectum, which was suspicious given his previous medical history. He therefore had a flexible sigmoidoscopy a day later, which showed only post-radiotherapy change, but unfortunately he still hasn't had anything done about his pronounced first-degree heart block with infection, and so on the 29th has a fall on the ward and is found to be in complete heart block. He's discussed at the local cardiology MDT at that point, where after a repeat echocardiogram, and the decision is made that he is still high risk. However, we now have a gentleman who's got a temporary wire in to treat his complete heart block, and who has active infection, and therefore how are we going to manage his rhythm going forward from here. So the CT head that's normal, not showing any acute pathology, the decision is made to transfer him to the tertiary centre in order to have further input with regards to his valve disease and with regard to his arrhythmia. So he comes across here and has a temporary permanent system placed. His transesophageal echocardiogram afterwards, with his rhythm being more stable, clearly shows a fixed anterior mitral valve leaflet. We weren't certain as to whether there was evidence of endocarditis on the mitral valve itself, but clearly he has significant regurgitation. And those amongst you who are cardiologists and cardiothoracic surgeons will have already probably spotted in the top right-hand corner that he has an aortic root abscess, but I'll show you that in a minute. But this is a 3D representation of the fixed anterior mitral valve leaflet and the posterior leaflet working well, and overall there wasn't any evidence of significant stenotic disease. These are the images more focusing on the aortic valve replacement itself. And we can see in the top left-hand corner the jet of paraprosthetic aortic regurgitation, the evidence of abscess in the middle picture, and then as that bottom picture pans through, you see the transvalvular regurgitation and also begin to see a hint of where the paraprosthetic leak might be coming from. He is therefore discussed at the endocarditis MDT, which I know people have alluded to, but for the team at Barts Heart Centre, that's made up of cardiology, cardiothoracics, microbiology, a radiology consultant who specialises in cardiac imaging, including in CT PET, and with a dedicated pharmacist as well who comes to the meeting on a weekly basis. So this gentleman is discussed. He's anemic, he's clearly quite unwell with an albumin mode of only 27. He's got a mild kidney injury. His inflammatory markers have settled completely, having now had 4 weeks of antibiotic therapy. And having been rediscussed with the new microbiologists, he had amoxicillin added in with the ceftriaxone to try and deal with the enterococcus. The valve lesions were discussed, and the CT PET was reviewed with no evidence of distant focus or of infection or malignant disease. And for the first time, his Euro score is calculated and comes out at 45%. The comment from the radiologist with ourselves is that this gentleman's course has not been ideal, and actually if endocarditis had been diagnosed earlier, that perhaps he may have ended up at the tertiary centre sooner rather than later. And so on the left-hand side is a very similar patient who's had cardiac suppression for his CT PET, and you quite nicely see the prosthetic aortic valve lighting up. And here in the rotating image with just the pure PET, you can see that lighting up within his heart in comparison to here, where the heart is obviously bright. The outcome from the discussion is that whilst he may have a very high risk for operation, he has virtually 100% mortality from his infection, and we need to make a plan for definitive rhythm management in that context. But clearly this needs to be discussed with him, and the option of medical therapy is there, but the risk of failure is high. The patient himself is keen for surgery after a discussion with the named consultant surgeon and also the cardiologist who's been looking after him. And the decision's made that given that that consultant surgeon is on call for the interceding weekend, that instead we would try and optimise him from a heart failure point of view. If he deteriorates over the weekend, then he'll go to theatre at that point. But as it stands, he went to theatre on the following Monday and was found to have a large abscess just under the left main stem with fresh pus, and he had an aortic valve replacement and an alveolar stitch with a ring to his mitral valve. Unsurprisingly, after 4 weeks of antibiotics, nothing was grown direct from the valve culture itself or on the 16S, but given the high-risk nature and the clear issues around antibiotics leading up to the surgery, he went on to 6 weeks of amoxicillin and ceftriaxone. He had the device implanted a week later after the epicardial wires were removed, or before the epicardial wires were removed, and was transferred back to his DGH, where he had 4 weeks of rehab, and 4 weeks after that was doing very well in outpatients.
Yeah, I think what's going to happen now is two things. The first is this. Chris, I think, is happy to answer any questions about the case itself. Firstly, from me, as if this was a court hearing, so that the court was able to understand some of the background to the main issues in the case. And then Bernard, I think, is going to act as a sole expert, a wolf expert, as I think they're sometimes called, in relation to... Actually, I suppose that might mean both ways, actually, a wolf expert.
In sheep's clothing.
Yeah. As Churchill would say, some sheep. Chris, thank you for that. The first question is this, and arises, I think, from a discussion we had earlier, which was the incidence of the pathogen in the bowel as opposed to root canal and dental abscess surgery. Certainly in preparation for this, I've been given to understand that it is an unusual presentation in root canal surgery, this particular pathogen, as opposed to the bowel. But that may, you told me about 10 minutes ago, be wrong.
So my understanding is that Enterococcus is very common in root canal surgery and in teeth. But the concern when it comes to bugs like this is that are we missing some other source, and predominantly a bowel malignancy? And hence, I think why the team at his local hospital went down the CT PET route to try and understand whether there was recurrence of malignancy or a new bowel malignancy.
So the radical and aggressive treatment for the carcinoma is something that would have been in the mind as this of the treating clinicians as a potential source of the pathogen in 2016. Is that right?
Correct, but I think at the same time the course of his history, with there being a dental procedure and a deterioration with infective symptoms thereafter, makes you significantly concerned that the source might be the teeth.
Yeah. So we get to the stage about what should be advised. This is pre the changes to the guidelines, about which we're going to hear from Bernard in a moment. But at the time of his original surgery in 2012, what should the cardiologist or the cardiothoracic surgeon have advised him in relation to prophylactic antibiotics in the future?
So I think the NICE guidance was clear about not advising prophylaxis. But given the clinical scenario, his consultant had made the decision that actually he should, because the risks were high. And actually, my understanding from having discussed this previously is that a lot of cardiac surgeons, if contacted by dentists, will advise for them to have prophylaxis if they feel the clinical scenario suggests that it's necessary, despite the guidance.
We may come, I think, because this was discussed also outside, with how easy it is to access the treating cardiothoracic surgeon at short notice from a dental surgery to get that information.
Absolutely.
But I'm sure Bernard will say it's terribly easy. But when we have the situation where the patient arrived with his initial abscess, he was treated with, did you say erythromycin or augmentin, I think?
We don't actually know what antibiotic he was given, but I suspect it was metronidazole or...
But he received antibiotic
He received
treatment.
a course of antibiotic, yes.
And that, if you like, failed.
Correct.
As a treatment. Do we know from his dental notes whether or not he passed on the information that he had received from his surgeon 4 years before in relation to prophylactic antibiotics and dental
Not
treatment?
Not from the dentist records, but the patient reported a conversation with the dentist saying, I'm supposed to get antibiotics, and the dentist saying, you don't need them, the guidance has changed, is essentially what the patient reports having happened.
But the first course of treatment was antibiotics. That failed.
Yes.
He then went back. The conversation was repeated, I assume, and he went ahead with surgery.
Without antibiotics.
Without antibiotics.
Yes.
And 2 weeks later, is this right, or was it 3 weeks later, he then attended his private medical clinic?
3 weeks, yes.
And then came in. So the first issue I think a court would have to consider is whether the dentist, in failing to give antibiotics on the second admission, was acting negligently. We're going to come back to this in a moment, because the provisional view is probably not. So one gets then to the admission to the hospital 2, that is, after his initial clinic and his presentation then. I claim no expertise, but if you bring up the ECG, please. His presentation was suspected IE, is that right, when he arrived at the hospital? I gather he gave a competent and full history.
Yes.
On admission. With a presentation of an ECG like that, why wasn't he taken straight to surgery?
I have absolutely no idea. I think is the honest answer. I think a gentleman who we know has a high-risk lesion, he has a typical bug, and there's no other clear source of infection other than the tooth, with an ECG like that, I have no idea why a cardiologist wasn't called, but furthermore, I don't know why things didn't move very quickly to have a discussion with him or a cardiothoracic centre about the potential need for an operation and a workup for one.
Because he didn't then have an operation for some reasonable period of time, isn't that right?
Yes, so he had the cardiac arrest 24 hours later and then was on intensive care and then on a general ward because he was felt to be too unwell to have an operation.
And can you anticipate a situation when any body of cardiological opinion looking at that ECG would come to the conclusion that there should be medical rather than surgical treatment at that stage?
I think because of his high risk, that was the prompting moment to have a conversation with the patient about what he wanted to have done, because surgery was not going to be without risk. But if you took all of that out of it, I don't think so.
Yes, because of course the patient's entitled to say, at whatever age he is, I don't want to have a surgery. It's 100% mortality from there with that ECG. There's no question about that, is there?
I think it'd be a very high mortality, yes.
Yeah. Okay, all right. Well, thank you very much. Any other questions that arise in relation to the background of the case?
And this was new first-degree heart block. Because you can get first-degree heart block after an aortic ulcer.
So there was no mention in the notes from the previous regional centre, and obviously when he first came in, he was in atrial fibrillation. There was no, we didn't know, but there certainly wasn't an active attempt to ascertain whether that was the case.
This was after his pulmonary and
No, on the day before. So this is before cardiology are involved. So this is under acute medicine.
I suppose he would have had post-operative ECGs at some point. So.
I'm sure it would have been possible to find out the information.
And just briefly, I think there was an issue, at least an issue was flagged up to me, about the PET scan and how the PET scan was done.
So I think the reason that the local hospital did the PET CT was different to what we might be trying to get from it if we did it to make a diagnosis of endocarditis. So the way that the PET was done was perfectly reasonable to answer the question about whether there was malignancy or a distant site focus of infection, but it didn't give you, given how easy it is to do it, to do this PET with cardiac suppression, it would have been an extra piece of information that would have been very helpful, I think.
But not determinative?
I don't think so. I think the clinical diagnosis here was of infective endocarditis.
And so when one looks at the necessity for surgery, what one would concentrate upon would be the ECG rather than
along with
badly done PET.
The valve lesion and the typical bug.
All right.
It would certainly prompt you to go down that direction.
It's a question.
Sorry, hello, yes, I'm Amanda Fife, consultant microbiologist at King's, who works on the endocarditis MDT. Just wanted a quick observation about the organism. It seems, unusually in this case, there's a very close relationship between a procedure, which has then been related to the subsequent development of endocarditis. Enterococci, less commonly found in sort of oral flora, although with this gentleman's long history of dental sepsis, it could have been that they were sort of replacement flora, having had sort of frequent courses of antibiotics to treat this dental sepsis. The other sort of, I would certainly be sort of interested in looking at other sources, particularly urosepsis, given his past history. So I'm not saying that it may have been a dental source, but I think it's perhaps less common. Yeah. Thank you.
I was just going to ask about his aortic regurgitation that was picked up initially. So that was thought to be moderate. So was that the same aortic regurgitation that was seen when he had the endocarditis, that paraprosthetic AR?
So what appeared to be new was the mitral regurgitation. So in all the letters, there'd been a comment about the moderate paraprosthetic AR, but no comments about mitral regurgitation. So the concern from our point of view and why the surgeon was going to go in and have a look at what was going on with the mitral valve was because whether there was evidence of infection there. But we didn't have the imaging because it was a different regional centre where he had the operation done.
So that paraprosthetic AR was probably old and not related to the infection.
Yeah.
And I just wanted to make a quick comment about the FDG PET, is that even if you do the dietary suppression, you don't always suppress the FDG uptake. In fact, in about a quarter of cases, you don't manage to do it. So that's the great limitation with that technique.
I'm just going to hold the questions here for a moment because I know one of our experts has to get back to court. So if we could...
Now, you probably saw I had my text and I'm waiting to see if I'm summoned. I'm not at the moment, so it's
very good. There will be
thank you.
There will be a period for further discussion at the end of the session. So if we could ask Bernard to step up.
Those are going to come in the summary at the end. So, Mark, I'm at your mercy.
I see, right. What we're going to concentrate upon at the moment are the NICE guidelines. I think, Bernard, you wrote a paper in The Lancet in 2015 looking at the consequences to the change in the NICE guidelines in 2008. Is that right?
Correct.
The position, I think, could be that in 2008, against the guidelines given in Europe, which are effectively, do I summarise this properly, that there should be prophylactic antibiotics in high-risk cases as a matter of course, against the US guidelines, which at the time, is this right, spoke of greater patient participation and discussion about what should be done. NICE changed its guidance to say that prophylactic antibiotics shouldn't be given at all in such circumstances. Is that right?
That's correct. So the NICE processes are very governed by the available highest levels of evidence. And there has never been robust evidence to examine this question. As I shall summarise at the end of the session, there has been a long-held belief that antibiotic prophylaxis is a wise thing to do on behalf of cardiologists and dentists, but it's a practice that has never been supported by any robust evidence by modern standards. And whilst the guideline committees in Europe and the US have taken a reasonable clinical standpoint regarding the targeting of treatment, in the UK, NICE took an approach based upon interpretation of robust evidence, and in the absence of any evidence, decreed that antibiotic prophylaxis was no longer appropriate.
And you undertook some analysis about the consequence of the change in the guidelines in 2008 to 2013 in your paper in The Lancet.
Yeah, so this is a group endeavour, so I mustn't take sole
Forgive me, my use of language.
In fact, it was led by other individuals, and I was a clinical contributor. But nevertheless, we were able to use data from UK NHS hospital admission statistics and hospital coding statistics, with their warts and all, it must be said, but nevertheless able to look at the incidence of endocarditis in hospitals in England in the period running up to the guidelines, the many years running up to the guidelines, and then look at the impact of the change of the guidelines in 2008.
And in short, you ran it up to March 2008 when they were changed, and I think what you found was there was a consistent upward trend in the population-corrected incidence of infective endocarditis. Is that right?
Yeah. So there was a pre-existing trend for the incidence to rise, but the gradient of that curve changed with an inflection point in the first quarter of 2008.
And this affects both high risk and I think lower risk, defined as low and medium risk patients. Is that right?
We weren't able to subcategorize between the different risk cohorts.
The guidelines then changed, and what were the consequences of a change in guidelines in terms of presentation of IE?
So there were two findings, in fact. The first was that the number of prescriptions for antibiotic prophylaxis plummeted by 90%. So dentists in particular took the guidelines to heart and changed their practice virtually overnight. And secondly, there was an increase in the incidence of endocarditis beyond that which would have been expected by the pre-existing trend at a statistically significant level.
And what limitations did you find in relation to that analysis?
So there were numerous limitations, as there are in any research. The first is that we did not have organism-specific data. So regrettably, we don't have a UK coding registry for the specific organisms causing endocarditis. So we weren't able to comment, for example, that the increase in incidence was related to more streptococcal organisms coming from the mouth and thereby inference coming from dental procedures. So we weren't able to categorise according to organism. We also recognise that there may be many other reasons why the incidence of endocarditis may be rising beyond the expected trend. So, for example, more prosthetic valves being inserted, or more implantable pacemakers or defibrillators, more instrumentation by means of cannulae with an increasing incidence of staphylococcal endocarditis. But having, within the limitations of what was achievable, explored these different hypotheses, we were unable to account for any of them as a cause of the trend observed.
I think you were unable to obtain any data anyway in relation to other groups of individuals potentially at risk of developing, i.e. people with diabetes, people in residential homes.
Exactly.
Features such as that. Unable therefore to factor in demographic changes over those 13 years, I think.
Indeed.
Was the period of time you were looking at.
So we were very careful in our conclusions to point out that we were not necessarily ascribing cause and effect relationship between the change in guidelines and the change of incidence, but there was a duty to report the data and to highlight the fact that we could not find any other explanation.
I think you summarise it in this way, that you'd shown a significant reduction in antibiotic prophylaxis prescriptions, which I think was 90%, yet at the same time a significant rise in the incidence of IE cases in England since the change in the guidelines.
Correct.
So that sense was, unproved, but that sense was the cause was the change. Would that be a fair way of putting it?
I think it would certainly be a fair inference of what we stated.
And so we did see a change in other papers published by you and others. I think people here in the British Dental Journal at the beginning of this year, February 2016, calling for a reassessment, putting out information within NICE. And of course, there was a second paper in August 2016 where NICE in fact changed the guidelines.
So there has been a subtle change in the guidelines, and one of the purposes of this session is to highlight this point because it is of very major relevance to cardiologists and those who are involved in the care of heart valve disease, and it also plays into the discussions that we've been having about informed consent and the principles of patient participation in decisions. But as a result of pressure within the Houses of Commons and the Houses of Lords, instigated by one patient's widow, more accurately, questions were placed to the Parliamentary Health Select Committee and thereafter to the NICE Committee. And as a result of that, they have softened their stance regarding antibiotic prophylaxis subtly, but importantly, to say that antibiotic prophylaxis is no longer routinely, and I emphasize routinely, recommended in patients at risk of infective endocarditis, thereby opening a rather large loophole in the previously very dogmatic guideline, which is open to interpretation by clinicians, dentists and patients.
Yes, and beforehand there was a flaw, which is you didn't. There was no positive recommendation to prescribe, but now there's just the importation of one rather perhaps legally loose word, which, going back to what I was trying to explain earlier in relation to Montgomery, is probably not frightfully helpful to treating physicians. Antibiotic prophylaxis against ineffective endocarditis is not recommended routinely for people undergoing dental procedures. So going back to this particular case, now that we've got a reasonably clear view of the background, and for anyone taking note, it's the British Dental Journal, 12th of August 2016 for the change and the paper on the change by Bernard and other people here, we have a presentation to the dentist with the patient giving the history by the cardiothoracic surgeon saying, I should have antibiotics before any treatment. And we know that the first treatment was, in fact, with antibiotics. Mm-hmm. We don't know whether that was caused by the fact that the dentist would have done that anyway, or whether that was caused by the fact that at the time the dentist made a decision that the cardiothoracic surgeon was correct. Mm. On the second occasion, when there was actually an invasive procedure, for some reason we don't know, the dentist changed his or her mind about the use of antibiotics. At the time the dentist did this, back in March, this was before the NICE change, what should have informed the dentist's treatment of the patient at that stage?
Okay, so I think that the dentist, there may have been several things running through the dentist's mind at that time. The first is that he or she had already administered a course of antibiotics for the dental abscess, which hadn't got better, and another prophylactic dose of antibiotics at the time of the dental procedure would have been unlikely to have had major impact. The second is that he or she would have been operating very comfortably within the NICE guidelines at that time, which indicated there was no indication for antibiotic prophylaxis. And indeed, he would have been supported by his Dental Protection Society, who also made very clear recommendations to the dental community that to administer antibiotic prophylaxis was associated with clinical risk, and that if there was an adverse consequence of antibiotic prescription, that the dental protection societies would not support their members.
Even in high-risk cases?
Even in high-risk cases.
So at the time of presentation to the dentist's decision initially and in the second appointment falls well within the bounds of a responsible body of dental opinion at the time.
Indeed. And given the comments that Amanda's made regarding the source of the organism, I think we can conclude, if I may conclude as a medic, that the dentist was not negligent.
Yeah. Going then to Hospital 2, and hearing the history a moment ago, it seems, at least to me, that the failure arose at the time of the ECG. Is there anything before that which would have led treating clinicians to conclude that immediate surgery was required?
Not in strictest terms before the diagnostic ECG. So the diagnostic sieve, as it were, revolves around a number of steps. The first is the clinical likelihood of this patient having endocarditis based upon their clinical circumstances, their clinical risk and their history.
And just pausing there, what would have been considered at that stage would have been the aggressive treatment for prostate cancer, and would have been considered the fact that there had been a dental abscess operation 2 weeks beforehand.
And thirdly, the fact that the patient has a prosthetic heart valve and presenting with fever and malaise and other symptoms very compatible with an infective illness.
It was said at the end of the presentation a moment ago that they could have been diagnosed, this patient could have been diagnosed earlier. And another slide was brought up, which is in the back of my head, so I didn't turn around to look at it. Do you concur with that view? That
I do. So having established the likelihood that this case is a diagnosis of infective endocarditis, we then use our clinical investigations to refine the diagnosis and confirm it. So the ECG is diagnostic of first-degree heart block, which, if confirmed to be new, would be very highly indicative of an aortic root abscess. Secondly, the echocardiogram would then be undertaken to confirm the presence or absence of the abscess. And if the transthoracic echocardiogram was insufficient, which I think you inferred it was because it was done in a sick patient on an ITU, then a deeper investigation by means of transesophageal imaging would have been appropriate. And I'm sure that that would have been sufficient to make the diagnosis without the recourse to PET and other investigations which are expensive and specialised and arguably shouldn't be undertaken outside the remit of the specialist centre.
Admission took place on the 12th of April. Systolic arrest took place on the evening, I think, is this right? I have the 16th, all right, 17th of April. Are there any circumstances where you can, looking at the history of this case, see that the diagnosis should have happened slightly earlier and he could have avoided going to a systolic arrest?
Yes, I believe so. But I would add that even once the diagnosis was clear and even once there were catastrophic hemodynamic circumstances, there was still delay to surgery. And that is a common scenario in endocarditis where there is delay at every stage of the process of diagnosis and treatment. So there is delay in initial suspicion of the diagnosis, there is delay in arriving at the diagnostic certainty, there is then delay at liaison with the appropriate specialist, i.e. the cardiologist, and then there is frequently delay by the surgeons before they operate. And all the while, the infection is continuing unhindered and causing irreversible cardiac damage.
So, looking at the 12th to the 17th, all things being equal and perfect treatment being undertaken, when should he have gone into surgery?
Well, I think he should have gone into surgery before the 12th, in fact, if I remember the timelines correctly, because he should have been referred from his district hospital to the specialist centre within 48 hours of arrival in hospital.
Do you know when that was done?
Weeks later.
Oh, I see. We didn't
Yeah.
We didn't
There
have
was a
that
period of
information.
several weeks, I think, from initial presentation to ultimate surgery.
So there was initial failure in terms of the local hospital referral. All right. Okay. Well, I've got no further questions in relation to that. Others may.
Thank you. I wonder if there is some loophole regarding the original 2008 NICE guidelines, because I think there's just one instance when they do recommend prophylaxis, and that is when there is a site of infection and there's a procedure at that site that might give rise to bacteremia.
Yes. So thank you for pointing that out, David. It was a point that we wanted to bring out in this session, but there was a caveat, you're quite right. It was not specifically addressed at dentists, but it was talking about other organ systems where the surgery may potentially be undertaken where there is existing infection. So, for example, in the urinary tract, if cystoscopy is being performed and there is a pool of infected urine, then it would be appropriate to give antibiotics at the time of that procedure.
Could one not expand that to say there was a dental abscess, which was a site of infection?
Yeah, I think you could indeed. I think it would then become a matter of semantics as to whether or not the patient had received antibiotics which had failed to be curative. We might also speculate that the seeding of the aortic valve had occurred before the patient even went to the dentist's in the first instance. Because, of course, although we speak a lot about giving antibiotic prophylaxis maybe once or twice a year at the time of visiting the dentist, there are many more days in the year when there is pre-existing periodontal disease and there may be low-grade bacteremia.
Yes, I agree. The dental abscess itself could have caused the endocarditis without the procedure being relevant. But in an ideal world, you could perhaps predict the possibility of having a course of antibiotics treating the abscess, which results in the viridans strep being replaced by enterococci, and that, having known that possibility, the procedure could have been covered by a combination of vancomycin and gentamicin to reduce any risk of bacteremia with resistant organisms.
I think that is a potential chain of circumstances and plausible biological events, but I think we've already concluded that the dentist was acting within accepted practice at the time.
I think it gives rise to a bigger issue now, which is, I think, something that was in common practice before 2008, back into 2000 or so, is this right, Bernard, that patients with aortic valve disease, in fact, carried cards, assumptive cards, is this right? saying, I am this patient and I require to have antibiotic treatment if I'm to have dental surgery.
Yeah, and I'm not the only person old enough in this room to remember those days, of course. But I think one unfortunate, perhaps unintended consequence of the NICE guidelines is that dentists and cardiologists have stopped worrying about endocarditis, because it's not so long ago that we would drum the potential risk of endocarditis into patients whenever we met them in the clinic. But now that we don't have to think about giving antibiotics, or perhaps have been persuaded by NICE that we don't need to think about it, we've stopped paying it attention. And I think that although until NICE change their guidance, we won't be giving them cards saying, I need antibiotics, I think we do need to be educating patients of their level of risk of acquiring endocarditis, focusing on the highest risk individuals. And by that I would be referring to patients with prosthetic valves, patients with prosthetic pacing or defibrillator devices, patients who've had endocarditis before, and not relevant to this audience, patients with complex congenital heart disease. Because these patients are at risk of endocarditis, and if they get it, the consequences are very, very serious. So even if they carry cards saying, I am a risk patient, it may help to remind the patient and their family, but also their general practitioner and their general dentist, that this is something that needs to be thought about should they become unwell for any other reason.
Where should this advice now bite? Should it bite with the cardiological clinician, or should it bite at the dentist? Should it bite at both?
I think there is a major responsibility for the cardiologists, and I think at the moment we're not accepting that responsibility.
So I have a brief question. In the initial presentation, the
just shout.
Close to this transponder. Do you want to shout?
I'll shout. The patient presented on the 15th of April. That was a Friday.
You're shouting at me, I hope not.
I think it was the 12th.
I got the 12th as mine.
Sorry.
Okay.
How long was it? Was endocarditis considered on the admission as a work diagnosis? And how long was it for the local cardiologists who were involved?
So the local cardiologists were involved until he was on IT, which was he arrested on the 17th. So that's 5 days in. I'm assuming the microbiologists were thinking that he had endocarditis because they had been involved and had changed the antibiotics. The acute medical team hadn't gone the next step to involve the cardiologists.
Do you, sorry, in answer to your question, because of course I can't give a medical answer, but did you mean at the local hospital before referral to the main hospital?
Yes.
Yeah.
Could I ask a question? You referred earlier to judges being allowed to weigh different types of medical opinion.
Yeah.
And I wanted to ask whether, given that NICE is a generic board of people with usually no direct acts and no direct experience of endocarditis, it's trialists, it's statisticians, it's people like that, non-medical people on the whole, whereas the European and the American guidelines were drawn up by clinicians and experts in the field who had experience of endocarditis. Would a judge be inclined perhaps to weigh more in favour of the European and American guidance and against NICE in deciding a course of action?
No, I mean, judges consider the circumstances in which diagnoses and decisions are made. The guidelines that NICE provide are not tramlines for clinicians, and judges do not say that negligence immediately bites because they don't go with the guidelines. They will go back to Bolam, albeit with the revisions on Bolam. They will look for what a competent body of medical opinion will say, and then they will see if there's proper reason to exclude competing competent bodies of medical opinion. So that's how they'll approach it. But you're absolutely right, and it's dealt with, I think, in reasonable detail in the original Lancet paper of yours, isn't it? That the Constitution, NICE, is very different from the Constitution of the European and American clinical organisations, and that therefore their sort of their medical weight is more limited, because there's economic, there's political, there's pharmacological factors that are weighed up. But they come up in court, and they're really floors rather than ceilings, if you like, in relation to the assessment of clinical decisions.
Thank you. I'm very pleased to hear you say that they're not tram lines, because I'm a cardiologist, worked down in Brighton, and we decided after the NICE guidance back in 2008 that we would continue to offer antibiotic, in fact to recommend antibiotic prophylaxis for patients who'd had endocarditis before and those with prosthetic valves. And really to empower the patients, we had some cards made to say that we still recommended it. And we then had the full force of politicisation really come down on us, fueled mainly by the chief dental officer. We were all investigated, we were taken off and interviewed, and we had statements. And in the end, nothing came of it. And we were delighted when the following year, the European Society of Cardiology guidelines on endocarditis continued to recommend prophylaxis along with cyanotic heart disease. And we could then back reference to those. And of course, the AHF come along and the revised European guidance. But it was a particularly uncomfortable area. And so often these things are viewed as this is the only way.
Well, it's always regrettable when there's a conflict between two professional organisations in terms of the dentists or otherwise, and cardiologists, which was taking place for quite some time. If it's of any interest, I discussed this with my dentist for the 5 hours I had treatment 2 weeks ago in anticipation's lecture, and they are now assumptive. They will always give prophylactic antibiotics in high-risk cases, which I'd like to think wasn't me.
I think particularly when you're aware of the group who made that decision, and the evidence Bernard spoke about the lack of evidence that they're going into.
Yeah.
Thank you very much. Fascinating session, Andrew Ludman from Exeter. So what do we do now? It's gone from a really simple area to suddenly really difficult. So what's your threshold?
So I'll be covering this in a brief resume, but I think we are now in a position where, as individual cardiologists, we are empowered to give a clearer steer for our individual patients. And I think there will be a greater understanding by the dental community that there has been a softening by NICE, and I think we need to be educating our patients as to where we stand as their what's the right word? As their guardian, as it were, as their physician, making decisions on their behalf. I think more broadly, there is a need for the British Cardiovascular Society and perhaps the British Heart Valve Society to take up the cudgel and work with the Society of Dentists, who are represented with the Royal College of Surgeons, and work out, and perhaps with the British Society of Antimicrobial Chemotherapy, to produce some consensual professional society guidance which everybody will be comfortable to operate within. And I think by doing so, we will have effectively shortcutted NICE.
So John Chambers will know, because he was largely involved on behalf of the BHVS, but we tried quite hard to engage with the British Dental Association. We actually wanted somebody from the BDA to come and talk at this meeting, and they weren't massively interested.
Mark, do you want to answer the same question from a legal perspective in terms of where do we go? I mean, we have to see these patients on a daily basis and we have to offer some advice.
Well, I'm not the risk person, but certainly the current NICE guidance and the word routinely is unhelpful. It's too woolly a word. It's therefore fantastic for lawyers' bank accounts, but it doesn't help patients and cardiologists decide. There clearly has to be a meeting of minds between the dental organisation and either this society or any of the cardiological societies, and perhaps have some sort of exclusionary list, so as to define risk, to define high risk, and perhaps to have, not exclusive, but to have some sort of taxonomy of cases where prophylactic antibiotics should be considered in writing. So it just needs greater clarity in just importing the word routinely. I think routine is incredibly unhelpful. I don't know what you all think. Bernard, I expect you to take rather the same view then.
Absolutely. Yeah, I mean,
it made it worse.
It's made it worse by creating uncertainty and a vacuum of responsibility. And NICE will certainly not step into that hole.
Hi, I'm one of the cardiac nurses from Guy's and St Thomas's. Just a couple of things, going back to those old-fashioned cards. The British Heart Foundation have now released new cards for patients. You can pick one of two. There's an elderly gentleman or there's a young lady. They both say exactly the same thing, but it does give guidance on picking up early warning signs of endocarditis for patients to carry now. I don't think it actually has any clarity on antibiotic prophylaxis, but it does emphasise things like tattoos and lifestyle things that are now designed to be given to patients. So they're available to be given out. From our perspective, from the valve clinic, the biggest question that we have from patients when you're trying to advise them on antibiotic prophylaxis is actually what constitutes an invasive procedure that requires the antibiotics. Because some patients ring and say they have very deep descaling, cleaning that provokes a lot of bleeding. Is that need to be covered?
Yeah.
Although it's not considered an invasive procedure.
So it's regrettable that there isn't a dentist amongst us,
Yeah.
but I can convey the message on behalf of them that it's any procedure that invokes bleeding. So anything that broaches the mucosa of the periapical region of the teeth, and I unquote.
So we have this
to you and me,
conflict.
if it causes bleeding.
So we have a conflict of an injection, if they're going to have a filling, but it might not cause bleeding, or deep scaling, which does.
What I do know is that deep scaling is pretty invasive
Aggressive.
in dental terms.
Yeah. Thank you.
Thank you. I've one more question, and then we'll move into your summary, if that's all right, Ben. So, excuse me. I'll be quicker to shout. Quick. Thanks.
Hi, thanks. Can I just ask, is the conclusion that we just don't know if prophylactic antibiotics make a difference? And because we don't know, we are being cautious, and therefore we think we should consider antibiotics in high risk. Because I suppose it would be interesting to follow up the next 10 years if we now increase our antibiotic use again to see if this trend changes. I suspect it might not change or increase further. But I mean, is it a fair assumption, if we've discussed this with patients, that we can't really say antibiotics definitely decrease your risk, but because we don't know, we're being cautious, and it's probably advisable that you should be on that?
So we don't know, and I suspect we will never know for certain, because there will never be a trial that will be done that will be powered to answer the question for every patient that we meet week in, week out. So we therefore need to use our clinical judgments, and as Mark has kindly said, we're pretty good at that. So is it sensible to give antibiotics to everybody with a floppy mitral valve and a short systolic murmur? No, because that means that we're giving antibiotics to many, many thousands, if not hundreds of thousands of people worldwide. We're encouraging antibiotic resistance, and we're incurring a very small risk of anaphylaxis. But for the patient with a prosthetic valve who's had endocarditis in the past, who needs to have a dental procedure and has 3 grams of amoxicillin twice a year, that's a very small risk intervention to prevent a very high risk situation should they get infection. So it's the bang for your buck.
Okay, thank you very much, and thank you for providing the final answer that the end result is there is no end result, and that we all have to exercise our judgments, which is what we like doing. Mark and Chris, thank you very much. It's great to have such a different take on this this issue. And now Ben is just going to finish off this session by giving a small lecture, picking up all of the details that have come out during this session. So
I just
thanks.
want to clarify, we want to finish at 1 o'clock?
Yeah, 1 o'clock.
So we've actually covered most of the subject matter of the slides, thanks to Mark's very skillful questioning and your very insightful questions as well. So I don't need to labour the talk, but I will just pick up the key elements. So we're not talking about our interactions with surgeons today, but our interactions with the legal profession. And I want to point out to you some of the very key take-home messages as to why this is the perfect storm and the perfect recipe for medico-legal action. The first is that the condition is rare, as you know, but its consequences are very, very serious. Secondly, it's supported by very poor levels of evidence, and there is controversy at various stages of the process, particularly in relation to prevention, as we've heard. Thirdly, endocarditis often arises as a consequence of an intervention undertaken by a doctor or a dentist, so there is a blame game involved. Fourthly, it is difficult to diagnose, as we have seen, in the hands of the non-expert. And I remind you that even in a specialist centre, you might only see 30 to 40 cases of endocarditis per annum if you are interested in the subject. If you are a general practitioner, you will see one case in your career. So this is not an issue in general practice primary care. The next factor is that there is a long incubation phase when damage is being done, which is then very rapidly followed by an escalation of events and hemodynamic collapse. So the opportunity for intervention is often missed. And then when the hemodynamic collapses do occur, the treatment is challenging and complicated and challenged by a variety of surgical, cardiological and other beliefs. We know that endocarditis is serious. I won't run through the statistics on this slide. To remind you, the in-hospital mortality is 20%. That probably makes it the most serious condition that we encounter on a week-by-week basis. There is a gradation of risk according to your clinical circumstances, and you can see that the highest risk patient is the patient with a prosthetic valve and previous endocarditis. And the magnitude of this gradient is very, very steep. We know about the link to dentistry, so I shall skip this slide, and I shall skip these slides as well. We have talked about the varying practices around the world, in America, the US, Australasia, and of course in our own dear UK. We have known for some years that the Americans and the Europeans have espoused a focused, selective strategy, offering prophylaxis to the highest risk patients, the groups we've already discussed. But we recognise that Britain, again, has taken its own independent stance, and NICE have recommended no antibiotic prophylaxis whatsoever. I include at the foot of this slide the point that David Shanson made about the slight caveat that if you are performing surgery or dental procedures for infection, then clearly the procedure needs covering with antibiotics. It's pretty obvious when you think about it, but it was in fact there in the NICE guidance. Here are the data I alluded to in relation to prescribing. A 90% fall in prescribing almost overnight, and the tail of the prescribing being thanks to Rachel, James and others who felt that they knew better than NICE and carried on with the previous regime, myself included. And here is the graph from the Lancet paper that Mark has kindly referenced, indicating the change in the gradient of the pre-existing rise in incidence, which coincided with the publication of the NICE guidelines in 2008. There have been attempts elsewhere in the world. Here are data from America, where, of course, the guidelines remain that you still give antibiotics to the highest risk patients, but there are some soft data suggesting that streptococcal endocarditis is also increasing in the States. So there is corroborative data from elsewhere. Here's another stance, another approach to the question, which is what are the adverse consequences of giving antibiotic prophylaxis? And in a companion paper, the same group of investigators, including myself, looked at the adverse reaction data to antibiotic prophylaxis regimes using the yellow card reporting system. And using the conjunction of the Lancet data and the prescribing data, we were able to produce this rather imbalanced scales, indicating that if the NICE guideline is practiced 100%, and if the Lancet data are true, then adopting the NICE guidelines could result in an extra 419 cases per annum in England, of which 66 would be fatal. Whereas if the ESC guideline strategy was taken, then this would result in 7 adverse drug reactions per annum, of which there would be 1 fatality every 3 years. But surprisingly, the fatalities are not related to anaphylaxis to penicillins. They are in fact related to pseudomembranous colitis relating to clindamycin. And if you use amoxicillin only, you get 2 adverse drug reactions and no mortalities. Now, I shall leave the interpretation of this slide to this august audience, but I think you can see where the balance of opinion lies. So here's a very brief resume of the ESC guidance. The main principles are self-evident, that we need to identify the patients at risk, we need to make them aware of that risk, and we need to make them and their dental practitioners aware of the importance of keeping the teeth healthy and considering antibiotic prophylaxis in the highest risk patients. Those patients remain the same in 2015 as they were in 2009, patients with a prosthetic valve, previous endocarditis, and cyanotic congenital heart disease. And in these patients, it's recommended that dental procedures which broach the oral mucosa and cause bleeding should receive protection by means of antibiotic prophylaxis, albeit at a relatively low level of evidence, Class 2A level of evidence C. So to translate, this is the evidence from non-randomized controlled trials based upon expert opinion and not a randomized controlled trial. I wasn't sure whether TAVR was a TAVI or a tissue aortic valve replacement, but I will highlight to you to the fact that TAVI patients are at least high risk as surgical AVR patients. And these are data from a number of studies, relatively small numbers, but TAVI is at least as risky as surgical AVR in relation to endocarditis. We've heard about the nice wriggle maneuver recently, and I will end on the conclusion that cardiologists are best placed to evaluate the level of risk in individual patients. It is our responsibility to communicate this to the dentist, whether the patient is at risk and what risks have been discussed, whether the different alternative philosophies have also been outlined, and which alternative the patient has chosen in conjunction with recent legal judgments. And then it's for the dentist to confirm this with the patient before proceeding to prescription. And really, we need to remember also that our goals as cardiologists and dentists are the same, that we have the same patients, we want the best outcomes for them, and to do that, we've got to work together. Thank you very much.
Thank you to all the speakers. Excellent session.